Okay. All right. Michael.
All right, you guys are live, so you should be good to go.
All right. Okay. So you begin? Let's begin. Hi, everybody. Good morning. As we say here in Navajo National, Yatek, what's Haba? I am Christopher J. Paisano, or Chris, NMAC's Indian Country Coordinator for our Escalate program. Escalate is our HRSA funded program and training created by NMAC to reduce, eliminate HIV-related stigma in right HIV/AIDS programs, parts A through D. So there we go. So welcome to our NMAC's webinar titled Native Health and Wellness, Closing the Data Divide. And we have as our guests two great individuals and professionals who are creating inroads and awareness to reduce public health barriers in Indian country and in Native health programs across the country. We have Kerry Lessard from the Shawnee Nation, who is an applied medical anthropologist working in the area of urban Indian health. And Kerry is also currently the executive director of Native American Lifelines, an urban Indian health program in Baltimore, Maryland, to educate, support, empower, and protect Native youth. As an undergraduate and at Florida Atlantic University, Kerry completed fieldwork with Haitian immigrants living with HIV in South Florida, and it was from this work that she became aware of the cultural uh, importance of culture and how culture shapes our understanding and interaction with health and wellness, but also how these deeply held beliefs impact decision making and behavior. So, in other words, deep held mental modes. Carrie's vision remains guided by the words attributed to Tecumseh, a great Shawnee leader. A single twig breaks, but a bundle of twigs is strong. Let me repeat that again for those who didn't get that. A single twig breaks, but a bundle of twigs is strong. And amen to that. And above all else, it is Lifeline's desire to grow a strong bundle. And we also have Dr. Evans, PhD, MPHCHES, which is Certified Health Education Specialist. Dr. Evans is a sexuality educator and researcher from North Carolina and is a proud citizen of the Haliwa Saponi tribe. Gabrielle, Dr. Evans, obtained her PhD in health promotion and behavioral health sciences from the University of Texas Health Science Center in Houston. Dr. Evans has taught comprehensive sexuality education since 2016, facilitating programs for faith based organizations, providers, and Native American adolescents. Dr. Evans' research focuses on researching sexual health disparities among Native American populations and analyzing the impact of historical and present traumas on Native sexual health. As a sexuality educator and researcher, Dr. Evans hopes to expand research on Native sexual well being, something that we will definitely talk about today. As Native researchers, Kerry Lessard and Dr. Evans are very qualified to share their insights around Native data collection efforts and can possibly share their challenges around encouraging Native governments to collect data and to have our own Native people included in national public health and HIV prevention and HIV services for those living with HIV. So, Carrie and Dr. Evans, welcome to our webinar to discuss, learn, and I hope to come up with solutions for our listeners around native data deserts, is how I like to play it, and how to overcome these challenges around native data collection efforts in a native data desert. But before we begin, I think a little background for a discussion, and I think many non-native listeners would be surprised that one, native people are still here in the U.S. We are clients in their programs and neighbors down the street, and we are often placed in other ethnic groups other than American Indians or Native Americans. One reason is that many programs intake surveys do not include us, and off the bat, we're already being not counted and being miscategorized. So please let me have you introduce yourselves. Carrie.
Okay. Well, I also want to say Ambawashte, Kerry Lessard, Machiapi, Tugashi Clark Craig, Ichiapi. I'm Kerry Lessard. My ancestor, one of my grandfathers, Clark Gregg, was a student at the Carlisle Indian boarding school and came from the Fort Peck tribe before moving to Montana. So I want to honor him because I think understanding that experience of trauma and culture loss really has impacted the work that I do. My family is also Shawnee and Irish. I am an applied medical anthropologist, as you said, and I am privileged to work in the Baltimore American Indian community in which I grew up. So I'm happy to be here.
Great, thank you. And Dr. Evans.
Well, hello, everyone. I am new to the Baltimore area. So I am originally from North Carolina, but moved to Baltimore from Houston, Texas. I've been in Baltimore for about 4 months now. So I'm still making connections with the Baltimore Indian community. I am a member of the Hallawasaponi tribe. And as Chris stated, I am a sexuality researcher and educator.
Great, thank you. And we just had an ESCALATE training in Charlotte, North Carolina. What a beautiful place. People are so friendly. I need to go back. All right. So as we begin, one of the things I want to talk about is, how is data collected? Is it done properly or improperly, or possibly both? Could you each both give us and our audience a general understanding of how data collection should happen and what happens instead for Native populations? For example, we've got tribal affiliations and Native Americans or American Indians. And so sometimes it's not able to list one or the other. So we'll start with Kerry.
So my quick answer will be an emphatic no. It's not being collected accurately. And I'll start with saying that prior to working for our Urban Indian Health Program, I worked with Chase Brexton Healthcare, which is a federally qualified healthcare program in Baltimore that focuses on HIV care. And when I took on my role here, we hosted our first National Native American HIV/AIDS Awareness Day. It was a little small affair. We worked closely with Baltimore City Health Department. I serve as on the HIV planning group. But we discovered that any of our relatives who were testing could only be white, Black, Asian, Latino, or other. So someone probably well known to all of us, Elton Naswood, spoke up to the Ryan White Bureau chief and said, when you do not count us, we do not count. And so it really took someone in a position of authority to go out to the testing vans and say, not only are you going to capture for American Indian Alaska Native, but you are going to capture for tribal affiliation. Because what we see is that still, and I pulled up data very recently, it still shows HIV by race and ethnicity in Maryland, and the choices are Hispanic, non-Hispanic Black, non-Hispanic white, Asian, and then non-Hispanic other, which is 33.5% of the new diagnoses, the second highest rate. So who them people are? Like they are, we have to make sure that we are understanding how HIV is impacting our community, giving people a place to indicate their identification as Native people and their tribal affiliation, because not only does that really show us the impact of HIV or other disease processes or other social determinants of health in our community, it's also telling us how we do the most effective interventions and getting the information to the communities that are in greatest need of the information. And so it's very poorly collected. I'm sure we'll talk about the different kind of horror stories we all have later, but I do want to take the moment to really credit Elton for speaking up and really changing the direction of things in Baltimore City while he was living in our area.
Great, thank you so much. And Dr. Evans, what is your take?
I agree with Kerry. It's definitely not been done accurately, if it's being done at all. So like Kerry mentioned, sometimes it's not even an option on demographic information surveys. And if it is, it's like it also doesn't give a place to write tribal affiliation. And one is basically like erasure all over again. Erasure is still happening. But also we know that numbers provide funding. And if we can't, like, we need to show the data so that we can get the funding.
Exactly. And I think I'm so happy that Elton had mentioned it, because, and my aunt, another auntie of mine, she talks about othering, the fact that we're stuck in there. And one of the things I think when I work with the Navajo Nation, and I heard as well as here at NMAC, is that, Native people do not have numbers. Well, because we're clubbed and other, we don't really have that, or even in the Latino group. So they'll, one of our clients will pick one or the other just to fit in there as well. So thank you very much. Appreciate that. And one of the things is, like, what are some real life consequences? I think you've already touched on that, Dr. Evans, of not having representative data in the community research. You talked about, funding as well. What other ways do you think that affects our communities as well as non-Native communities, Dr. Evans?
I think, like, speaking on a personal experience, personal experience, I think one thing too is, like, if you go into a medical facility and, they have you misidentified on your demographic information, there's certain ranges that your lab should be in for certain races and ethnicities. So if you're marked as the wrong race or ethnicity, then your labs can be misinterpreted. So I think that's a consequence, like, not just for the, community overall, but, individual health. So that's definitely a consequence. And I hate to keep going back to funding, but I mean, money runs everything. So that's definitely like a community consequence, whether it's funding for health resources or, whatever other resources that are available. Like, we need, it goes back to that erasure. Like, people don't think we're still here because the numbers don't match.
Exactly.
I will say I appreciate the humor of Natives when it comes to things like this. I remember, I think it was like during an election or something, we got labeled as something else. So then social media took a run and we just start, I'm something else now.
Something else. Exactly. Your experience, Kerry.
It absolutely mirrors that of Dr. Evans, but also, again, the way that those things, if we look at them from the high level, like, how does it impact data collection? And not to say that's not important, but also, how does it impact people and their understanding? So, I again, in my role as an HIV planning group commissioner, I was in a meeting with someone who is an epidemiologist at the state of Maryland, and I asked him to unpack the data for me on the number of our people who were impacted by HIV. And in a public meeting, he said, your numbers are too small and they don't count. And while I stood there with my jaw hanging open, Dr. Patrick Chalk, who was again the HIV bureau chief for Baltimore City at that time and an ally, stood up as, again, someone with authority and a platform to say that they do count and we need to start counting them. And so he worked with, at that time, Commissioner Dr. Leanna Wynn to ensure that at least in the Ryan White Bureau, American Indian Alaska Native was captured. But then, the other problems are just those things that, can be seen as microaggressions or really just aggressions. And I'll use the name of a friend of mine, Leanne Bruised Head, who's Crow. I'm going to borrow her name for a moment because we had a community member who went in for care and had a name similar to that. And when checking in, the person checking him in at Johns Hopkins Hospital, which is this esteemed institution, said, I didn't ask you what was wrong with you. I asked you what your name is. So because our people come with these wonderful last names that have such legacy to them, to be treated that way, this person doesn't want to go back there. This person isn't going to be treated, or going to even, as stigmatizing as talking about HIV and sexual health can be, if someone's already not respecting your name, something as simple as that, if they can't get the small things right, you are not going to trust them with big things. So that continues to be a problem.
I'm glad you mentioned that, because I think stigma is not even just with non-natives, but even within our own community, stigma and trying to talk about sexual health. It just depends. And all nations aren't the same, right? Navajo can be sort of progressive and then sort of not in different areas as well. So I'm glad that you mentioned that. And also, you would think after coming out of COVID, well, not coming, well, we're over the hump, we hope, but we still will have COVID for the rest of our lives. You would think that looking at numbers and people saying that they're small, well, COVID began from one person who was exposed and took it back and it changed the whole world. And so even in our native communities, some places are insular and some places aren't. But you would think that we can use that example of COVID with other people and say, look, it starts with one person. This is why it's important. One person did change the world and change it drastically. Do you think that if we start using COVID as an example, will that help change the dialogue and the discussion among those people who the powers that be?
I'm honestly, having worked in the HIV field in one way or another since the late 80s, I am surprised that we didn't learn lessons from the HIV epidemic and apply them to COVID, because that seemed so obvious to me. I just, being, just taking into account what our risk factors were and what could we do to prevent. That was just something that was so normalized, at least back then. And it was so strange to me that with regard to COVID, people were kind of flouting, their decision not to take any protective measures. So I was just surprised that we have such an example on how to treat infectious disease. Things weren't always great, but we did things right, and there was a roadmap. And I think I just don't understand why those lessons learned weren't taken into account when we were doing more COVID planning. I think that was such a missed opportunity.
Great, thank you. And so Dr. Evans, also on that same train thought there, what have you experienced? And I guess if you came from either Texas or from South Carolina, in those states, what did you find out with COVID, and how can we apply what we learned or should have learned in the HIV field?
Texas. We all know how Texas is.
I was going to assume.
I think Texas can take some lessons learned from other areas and apply them. Yeah. Coming from Texas, I don't think I have much to contribute to that one, but I hope that they take things from other areas and apply it.
Exactly. One of the things that you guys had touched about and made me think about it when I was trying to develop some other questions was, I think in a lot of the tribal nations and programs, what we have is, okay, we collect data, but sometimes more data isn't necessarily the best data. So you've got qualitative data versus quantitative. How do you think in your experiences, either Native operating organizations or tribes themselves know what to do with this kind of data? Because of medical mistrust, this is why, a lot of tribes do not share their data or want to share their data.
Yeah, so I actually had that firsthand experience. I was working on a project in my PhD program, and I was trying to get, I think it was actually Hopkins data, and the tribe didn't want to share it, which I completely understand and I respected it. So I get, why tribes are holding on to that data. I think when I'm hoping that, so I work for the Center for Indigenous Health, and I think with organizations like that, where we are serving, like we're Indigenous people serving Indigenous people, or even Lifelines, like I think there might be a little bit more trust that way. That's still to say that there might be some apprehension with sharing data. But I think if we have entities like that, or even just, building those community connections, that's helpful. So, I started my PhD program literally right before COVID hit. So I never got a chance to build community with the Native communities in Houston. So when it came time for data collection or conducting research, like there was no way that I was going to say, hey, I need to tap in with y'all to for my research when I haven't even built a connection for that. And that's not even like, I wouldn't even try to say, oh, I'm going to connect with y'all now and then later try to get data. Like, I just would not do that because, you know, we have to build those connections with the communities just, you know, for the sake of building connections. And for me, moving somewhere where I didn't have that cultural connection was big. Like, I wanted to have that, but I just couldn't do it because of COVID. So I say all of that to say I think it's important to have those meaningful relationships, and not to have like to genuinely have those meaningful relationships and not have the ulterior motive of like one day I'm gonna need data from y'all, but like to just genuinely just build those connections in the first place.
So we're talking about trust, you know, building connections, building those bridges so that our community can understand what we're asking for and everything. Kerry, on the same line of building trust and also trying to get qualitative data, what has your experience been so far?
So I had a somewhat different experience, and I, you know, do qualitative data really only. But, you know, working in my community, and I worked as a graduate researcher with the Friends Social Research Institute on a CSAP grant that they had, because I was working in a community where people have known me since I was a child, or I've known them since they were children. I already had some rapport, you know, built in that I could ask questions, not, you know, people still, because we were talking about sensitive things, especially around sexuality and gender, that, you know, were uncomfortable. You know, ultimately, I think it helped being, to use an anthropological word, embedded in my community. I also, you know, being part of a network of other Native organizations, you know, working with people like Melvin Harrison and Marco Arvizo at Navajo AIDS Network, or, you know, receiving support from Pamela Jumper Thurman, you know, just getting sort of a broad experience. And by the way, I don't mention them to name drop, but really to honor them because they contributed to me so profoundly, and I'm forever indebted for all that they did for me. But really, especially like spending time with Marco to see how in Chinle, for example, you know, AIDS prevention, HIV/AIDS prevention, you know, was done, and how, you know, you mentioned how in some ways Navajo Nation is very progressive, but in other ways like conservative, and how do you parse that out, and how do you have conversations about sex and gender? Here in Baltimore, there is a significant segment of our population that is very evangelical Christian, and so, you know, sometimes our LGBTQ two-spirit relatives would not necessarily want to be in certain spaces where they would feel judged. So I think it's really having to understand kind of how communities operate and who you can talk to and kind of where you can fit in, and then how to have conversations in ways that people in the community can receive those conversations, that the information is still credible, and you're receiving credible information, but how can you have conversations in the way that people can receive them and still feel okay about them?
Great, thank you so much. And I think as we progress a little bit further, I think what we're now beginning to see are some intersectionalities among all these things that are going on. It's not just simply, I'm gonna go in there and take data for the benefit of Native people, boom. No, there's all kinds of things that intersect, and why we find different pushbacks, you know, among all Native people, and, you know, in specific areas. So with tribes, I know, you know, in trying to win over or to best make an argument of why this is important, we talked about funding streams and us being, if we're not seen, we're not on the table, we're not even on the radar. In your work, how have you been able to advance your research when dealing with non-representative data samples? Because if we're not there, how then can you make the claim and say, you know, we are there, we are important? And especially, I'd like to hear your experience with tribe specific, because I know there's a lot of pushback even with tribes. And we'll go Dr. Evans.
Yeah, that's a good question. I think one thing is just, I mean, coming from the perspective of a former doctoral student, like pushing, like I was very adamant that my dissertation research would focus on Native people. And I'm like, I will not focus on pleasure before I like drop my population. Like I will give up something else before I drop this population. So standing firm in that was what helped me. But I also had the support of, you know, my dissertation advisor who had been working in the community, was an ally. And then also I had built relationships with Healthy Native Youth and Project Red Talent partners over the course of my time in school, that when it came for research, like I had them that could vouch for me and could also like help me get a representative sample. You know, my research for my dissertation, the participants did not have to identify as Native, but they had to work primarily amongst Native adolescent and young adult women. So their priority population had to be that identity. So I was able to, you know, get that data, and it just so turned out that more than half of my sample was identified as Native. But again, building those relationships and, you know, with the tribes, you know, showing the need for why we need to do this work and how it can benefit the tribal community. So, you know, a source of healing. You know, for me personally, looking at the impact of trauma, and, you know, generational trauma is a thing, is historical trauma is passed down. So, you know, trying to also frame it as like, this is why we need this, and this is how it can benefit the tribal community as well as like research.
Got to unmute. I'm glad you talked about, you know, in your efforts in trying to build trust, as well as having advocates, those people who, powers that be, I like to call them, who know exactly what you're trying to do and can speak on behalf. And I think, do you think, just as a side question, do you think what your experience was in having, you know, inroads, as well as having professionals be advocates for you, and it's in sharing that experience, will help other Native researchers or other researchers who want to do work with Native people?
Yeah, I think that will be helpful. I will say that I did, despite having all of those advocates, I did get pushback from, I remember somebody distributed my dissertation flyer, and somebody emailed and said, did this person receive support from the community? Because there's an issue with, basically they question my identity as a Native woman. So I don't always to some people I don't present as quote unquote Native. Like I don't look like I'm Native, whatever that looks like, because we all look different. But so I got, you know, she questioned my identity as a Native person doing research, and I was like, I got IRB approval, and I am the community. Like I am the community. So, you know, I think it's helpful to all, you know, having that support to get you in those spaces, but also having that community you can rely, you know, those safe spaces that when something like that does happen to us, like somebody to, you know, support you during that is also important.
And I'm glad you mentioned that. And I'd like Kerry to sort of build on that discussion next, is that when you get pushback, even from our community, is some of it's pushback because of medical mistrust, but some of it can be pushback just because they're like, oh, you don't look Native, or you're not Native, or all these assumptions that people do because we're people. In Baltimore, in your experience, have you ever experienced anything like that in trying to, you know, either advocate to get data, or, you know, in bringing your services to the Baltimore area?
Yeah, definitely. You know, I have worked really exclusively in urban and intertribal spaces. And I think, you know, just thinking of the experience in Baltimore, again, working, you know, wanting to have approval from the community and from elders in the community about how we're going to proceed, but still trying to combat, you know, just being honest, like homophobia and transphobia, and then stigma around substance use. You know, it really took, again, relying on personal relationships to say, like, hey, you know, this is really important in our community. And for us having conversations about, like, you know, we want to take care of our relatives. We have these values as Native people, and we want to keep our relatives alive and with us. And so kind of using that language, I think, was really important. But then just speaking with people in our community, the focus of the graduate research that I did was around historical and intergenerational trauma. But what that looked like in Baltimore was also community trauma, that Native people, a large number of whom are Lumbee, living in Baltimore, that the community around them doesn't see them as Native. And that was a source of trauma for them. And that other tribes didn't see them as Native because they're state recognized tribes. So that was a source of trauma. So really looking at, they communicated, I guess what I want to say is our community members communicated very clearly to me that they felt that those things, that not being seen as Native or not being seen as Native enough, prevented them from achieving and sustaining wellness, and also increase the likelihood that they would participate in health demoting behavioral practices. And so those kinds of things place them more at risk. So in our community, there was a clear correlation for them between not being seen as Native people or being invisible in the larger community, and the types of risk behaviors in which they were willing to engage, or the type of risk that they were willing to assume, and how they felt trapped in that experience of risk and shame and stigma, that really doing the work, which was cultural healing and culturally grounded programming, that is what they could sort of lift out of. But it wasn't until that they felt that they could really see themselves as being in the process of healing or whole, which is very sad.
I'm glad you mentioned that community trauma too, Kerry, because that's definitely, coming from North Carolina, like we're all state recognized tribes, and then going somewhere else and it's like, oh, but you're not federally recognized, or like rural natives get left out, I feel like, all the time. So, making sure, like one big thing with my own research is wanting to make sure that rural tribes are not forgotten about, because when it comes to research, a lot of times, and I know, we're smaller, but, making sure that we uplift those communities as well is important to me.
I love you said that, uplift, and that's one of the terms I've learned doing ESCALATE. And because all these stigma are barriers, and you're talking exactly about what happens and why we can't get, it's difficult enough to get folks in the door to talk about HIV health and prevention is sexuality health, and then to have another layer of stigma and having the community not participate I think is a big barrier. And on that barrier, one of the things you think, because we talked about data quality, do you think that tribes, or even in tribal health programs across the country that you've dealt with, do you think that we are asking the right questions? It's one thing to ask about where you're from, which is a great thing. Another thing to ask about where is your tribal affiliation. But then after that, sometimes community just receives these cookie cutter questionnaires, and we just think that that's from God on high. And how do we get down and really look at, is this something we need to do? What are your experiences, Dr. Evans?
I think, which I know it's not going to be easy, but I mean, it's necessary. I think it's important to make adaptations based on like region or, location and tribe. So, I mean, it will be a very tedious process when we're talking surveys or questionnaires, but I think in order to go beyond the cookie cutter, then we need things tailored to those specific regions and geographical locations to tailor the needs for that community.
Right. So that we don't always have cookie cutter. No one shoe fits everybody. And so, Kerry, in your program, do you find that if you're going to implement a new survey, do you find that there is resistance just because this is the way we've always done it? And so to change a deep held mental mode is very difficult. What are your experiences there?
I think there are some people at the Maryland Department of Health that like see me somewhere and are like, oh crap, there she is. She's going to talk about data again, because I do every time. I mean, the last meeting with the Maryland Department of Health, I was like, in the year of our Lord 2023, you can't tell me that we are required to collect data for every other thing, but we can't get this right. I mean, I've been for 23 years, I have been working on how we can do this better, or really trying to advocate. And I can't understand why it is so difficult. If, for example, for me to receive a grant, I have to provide certain information and it is required of me to do it. And if I do not do it, I will not continue to get funding. I don't understand why that kind of data cannot be collected. And then the grantor, the funder, can't say you must collect it in this way. You must use SOGI data in this way. Or so, I just, that doesn't make any sense to me at all. It's very frustrating. And so, yeah.
Well, congratulations to you both for keep pushing it and everything. And one thing, I had a real quick conversation with Harold Phillips from the White House, and I told him, these are things we need to do. We need to change. We're doing our time, what we can is from the program level, on the community level. We also need to have your voice down below and to change those folks. And like, this is required. This is something interesting. And I see we're almost getting to that point here. But one thing I wanted to do is just talk about real quickly any data stories that you can share among yourselves, or among the listeners. Things that have been challenged. You've already shared them up, but is there a specific one that you can talk about and sort of help us all see that picture and how real it is for our communities?
I think it's not specifically related to HIV research, but I think it is important. So I've had 2 instances where I've gone to the doctor and they've changed my race. One time they changed it to white, one time they changed it to black. So I went in, like I was telling the front desk person, and I was like, hey, I updated my race online, but I want to make sure that it's correct in the system. And she literally looked at me and said, American Indian, where the hell did they get that from? And I'm like, that's what it's supposed to be. Like, you had it wrong. So I had a conversation with my provider when I went back, like to the exam room, and she was like, that's not okay. Like, I'll handle it. And the next time I went back, she let me know. She was like, I had a conversation with her, like, and I actually didn't see that person there anymore. But I think they had some real serious conversations about it. And, that goes back to my labs. Because my race was wrong, my labs could have been misinterpreted, or that goes to the erasure. Like, there's so many things wrong with this. Why, one, you shouldn't have assumed what my race was, and 2, your response when I corrected it, like, that's my data story. And this is why it's so important to believe, don't question my Native identity. I don't know. Do you need me to pull out my tribal card? And some people don't have a tribal card. So yeah, that's my data story and why data needs to be accurate.
Exactly. Thank you so much. And Kerry.
Just one thing also, not HIV related specifically, but in Baltimore City, we had 2 Native women who were murdered, Tiffany Jones and Yasmin Wilson, both who were members or descendants of the Lumbee tribe of North Carolina. Tiffany was listed as being white. Yasmin was listed as being black. So in life, I felt like their identity as Native women was erased. And then in their really horrible deaths, their identity as Native women were erased. And so to me, that is the most palpable example of why data is important, because, it took Abigail Echohawk from Urban Indian Health Institute to advocate for Baltimore City to report on Tiffany and Yasmin as being MMIW. So it's just, data matters. It just does.
And I mean, there's hundreds and thousands of cases of MMIW, but I believe it was only around 500 or so have been logged into the DOJ database, because in this underreporting, it's identity erasure, it's a plethora of reasons, but it all goes back to the data, which also it doesn't, those low numbers, when the numbers are higher, I feel like people aren't are seeing it, oh, it's not a big deal. But like, no, it is a big deal. These numbers are higher than what people think, and it's affecting communities big and small.
Exactly. Thank you so much. I really appreciate, those stories, because I mean, it affects everything. Data, or just data, and being aware. Being aware of Native people is what affects us. Real quickly, we're about to end, but we have some questions. But I just wanted to really point out, like Rick Haverkate, National HIV/AIDS Program Director in Indian Health Service, he's offering technical assistance around data collection for HIV, HCV, and STI data. So, definitely our community, if you don't, definitely reach out to Rick. And I know that's something that he is really trying to push with all of us as well. And so, Taylor, there are a few questions from our watchers. So I think Taylor's going to read them out, and then we'll have you both answer them.
Yeah, there sure are. And is that okay? I know we're at time. Do you all have 5 minutes to answer questions?
Yes,
Thank you so much. I appreciate that. So real quick, before we do that, I just wanted to share a quick message from the CDC. Did you know HIV tests can be done in your own space and on your own time? Knowing your HIV status can help you live your best life. For more information, go to cdc.gov/HIV self-testing. Okay, so our first question is, if a tribe is federally recognized, are they eligible for Ryan White funds? It seems that if accurate counts are provided, communities will be eligible for additional Ryan White resources.
I don't actually know the answer to that question. What I will say is there was a point when, during the last administration, when Dr. Redfield from the CDC met with us. But boy, this is where I really wish that Rick Haverkate were around. I'm sure that, because tribes can receive healthcare from IHS, but then tribes as sovereign entities can also receive other types of funding if they seek it. So that's a non-answer, and I apologize.
Actually, I think I can answer that. They can, because we have over here in Gallup, they receive Ryan White funds, and then different areas. I believe also there's a clinic in Oklahoma. They receive Ryan White funds. So yes, tribes can get and access to those programs.
Okay, and we had a follow-up comment as well. It's that says, I know for TGA regions, Ryan White funds are based on populations of people living with HIV. So another question is, why do you think this is being allowed as far as the inaccurate data? Like, who does it benefit? Because it sounds like it's a lose, even for the people who are, collecting it inaccurately. So do you think it's just careless, or like there's a benefit somewhere to not being accurate?
I think it's a carelessness and laziness issue, if I'm being completely honest.
And settler colonialism,
Yes.
I would say.
Absolutely, 100%. I guess just for one last question, do you have any examples of, like, I know you all had mentioned earlier that there might be tribes hesitant to hand over certain data. Can you point to an example of data being used to abuse a population? Like, I've collected it and now I've misrepresented you in some way that's caused you harm, or you get what I'm sort of mean?
I am not personally aware of any.
Neither am I.
Okay, I'll put my 2 cents in. I know in the state of Arizona, I'm not sure whether it was the state themselves or it was a university, but had done collecting data. Oh no, it was down there in Havasupai. They were collecting blood samples. And so what they didn't really tell them exactly what they were going to do for that, but they collected them and they started using, I think it was for diabetes, but then they used that blood sample to look at other health outcomes that was not presented when they collected it. So they were using samples illegally for other research purposes. And so this was a big thing that the tribes came up against and said, no, we're going to close the door. And it's because of things like that, which demonstrates exactly what our guests are speaking to about why there's medical mistrust in Native people. And trust.
And Chris, not to interrupt, but I know that that's the issue that you're speaking of. The Native Biodata Consortium is really trying to address the abuses or misuse or the surreptitious use of Native genetic material.
Great. Thank you. Appreciate it for that clarification. Exactly. And this is almost, hopefully it's not rampant, but when it comes up, we all are surprised when this happens. Oh, okay. Taylor, is all
that's it. Yep.
All right, y'all. So you know what? Thank you all both so very much. Again, we have Kerry Lessard, Executive Director of Native American Lifelines in Baltimore, Maryland, and Dr. Evans, researcher extraordinaire and a sexuality educator and researcher from North Carolina, who is now in Baltimore and a proud citizen of the Haliwa Saponi tribe. And thank you, audience, for your time. Let us all push forward and increase Native visibility and data collection efforts. Thank you all so very much from NMAC, and you all have a great day and a great week. Thank you all.
Thank you.